Get our next presentation online, and we're going to be hearing from Dr. Alan Frizzetti. Dr. Frizzetti is Associate Professor in the Department of Psychology at the University of Nevada in Reno, and is also Director of the Dialectical Behavior Therapy and Research Program in the Department of Psychology there. He's participated in these NEA.BPD programs at other locations, and is one of the really leading educators and researchers looking at DBT in a very intensive way. So we're delighted he could join us to tell us about what's new and what are the current views in terms of DBT. Alan.
Great. Thank you. Well, good morning. Thanks so much for inviting me. It's a pleasure to be here. I've got a couple of tasks here this morning to follow up on the tantalizing introductions that Drs. Bohus and Trestman gave us yesterday about dialectical behavior therapy. I'm going to try to do a couple of things. One, I want to describe DBT in a little bit of detail because there continue to persist some myths about what DBT is, how it's used, and in fact, lots of consumers bump up against a situation where somebody says in the community, gee, we have a DBT program, and it turns out what they're offering is a piece of DBT, which may or may not be useful. Some of the data tell us that sometimes that can, and sometimes it might not be, as Dr. Trestman mentioned yesterday. And so it's important to know what it is that we're studying when we talk about a comprehensive DBT program. And I also want to talk about the more and more data part, because as it turns out, over the last 15 years, there's an enormous body of research on DBT that I think it's worth taking a look at, and including today some hot off the press, actually not yet in press results that I think are interesting to note. First of all, just in terms of defining dialectical behavior therapy, dialectical behavior therapy is unlike other therapies, at least most other therapies, in that it's not just one thing. It's not the sort of thing that you do between one provider and one patient. It's actually a program of treatments that has at least 5 different parts. That doesn't mean there are 5 different providers, but there are 5 different things that the treatment is trying to accomplish, and usually is accomplishing those in a variety of ways. The first is to enhance patient capabilities. Now, we typically think of those capabilities as skills, and Marsha Linehan, of course, who's developed DBT from the beginning, has written a skill training manual which includes modules for mindfulness, emotion regulation, distress tolerance, and interpersonal effectiveness skills. But in principle, of course, DBT aims to help patients learn whatever skills they might need, whatever lack of skills is interfering in their life. But those particular sets of skills are prominent. But then the behavior therapy part of the dialectical behavior therapy treatment also endeavors to generalize those skills to the patient's actual life. It's one thing to be able to learn how to drive a car in a classroom, as I've been explaining to my 17-year-old son. And it's another thing to be able to do that effectively in traffic in Reno, where traffic is not like where I grew up in Boston. And it's another thing to be able to actually do it in rush hour in Boston or New York or San Francisco. Those are generalization skills. And in fact, our clients live lives on the fast lane in big cities, and so they need to have really good driving skills. It's not enough to simply sit in the classroom and say, okay, I know that you're supposed to turn your turn signal on, a couple of hundred feet before you take the turn. You've got to actually be able to remember to do that and turn it on in the right direction and so forth. So generalization is an important component of dialectical behavior therapy. There's also the component that we refer to as enhancing patient motivation. And that's a kind of a strange way of putting it. This is typically done in individual psychotherapy, although sometimes in some of our studies is actually done in groups. But enhancing patient motivation has to do with understanding the antecedents and consequences of problem behaviors. What are the antecedents, the chain of events, both in the world and privately the emotions and thoughts and reactions of the person that lead somebody to behave in a way that's problematic, as well as the consequences that might reinforce that or might fail to reinforce alternative, more skillful behaviors, as well as what are the antecedents and consequences that we need to provide in order to change those behaviors and get the person to do something that's much more skillful when they need it. It turns out that in order to get somebody to make all those changes, you've got to provide an enormous amount of support and validation. So this component, this enhancing motivation, has a lot to do with the dialectic of acceptance and change, and we'll talk about that in a minute. But enhancing patient motivation is, of course, a core component of the treatment. But we also in DBT recognize that treating chronically suicidal, self-injuring, sometimes aggressive, and certainly depressed and otherwise suffering people can be a burden for the therapist. And so actually paying attention to the therapist's skills at providing the treatment well and their own motivation to do so, to stay in balance, to not burn out, to actually like what they're doing, and to like the patient. Those are an integral part of the treatment. Those are not things that are left to chance, and in fact are an ongoing component of the treatment. And we typically address that in ongoing peer consultation teams. And so DBT is in fact a team treatment that way. This could of course be accomplished in other ways, and sometimes is in terms of ongoing supervision, but peer supervision and consultation is the primary way that we address therapist skills and motivation. But we also recognize that other people in the social and family environment have a role to play, and that role could be problematic or could be incredibly useful in facilitating. And so we try to make sure that we involve the social and family environment to the extent that we can to promote good outcomes. And so family interventions are also an ongoing part of the treatment. So sometimes, even in my own city, sometimes I hear people saying, oh, I've had DBT and it didn't work. And I say, oh my goodness, what happened? And say, well, my therapist, gave me the skills training manual to read, and I read it, and I really don't feel any better. And of course, that's not DBT. That's not quite what we mean by DBT. It's really got to have these 5 parts to be considered DBT. Now, as we've been talking about yesterday and today, there's a lot of debate about the various ideological pathways that people can follow to get to borderline personality disorder. But within DBT, we define specifically BPD as a pervasive dysfunction of the emotion regulation system. And we would say that, therefore, all of the problem behaviors that people with BPD have are either those behaviors function to regulate emotions, somewhat dysfunctionally, of course, but they function that way. So cutting and substance use and overdosing, binging and purging, dissociating, and so forth might often have similar escape functions, regulatory functions. The person is at a high level of aversive tension, as Dr. Bohus calls it, or aversive arousal, as we might call it. And those behaviors help the person bring that negative emotional arousal down. And in a behavioral sense, we call that negative reinforcement. So some of the behaviors that we associate with BPD actually function to regulate emotion, and others are just simply natural consequences of having chronically and pervasively dysregulated emotion. Marshall Linehan has kind of lumped together the various DSM criteria, the indented white letters here, for BPD into areas of dysregulation, emotion dysregulation being the core, but then around that revolving interpersonal, self, behavioral, and cognitive dysregulation. And so consequently, the skills in DBT are designed to provide a platform through which these areas of dysregulation can be addressed. The patient can learn some certain skills in skill training. The therapist can help that patient incorporate those skills into their daily life in situations where they need them to re-regulate their relationships, their emotion, develop a stronger and healthier sense of self, have self-control, reduce impulsivity, and so forth. Now, DBT is predicated on what we would call a biosocial, or what we often call a transactional model for the development and maintenance of the disorder. Now, this biosocial model or transactional model isn't necessarily completely specific to BPD. That's one of the, on the one hand, one of the weaknesses of the model. On the other hand, it's one of the strengths because it's also a way of accounting for what we think of as comorbidity, or what I think of as just messiness. The fact is that our patients have lots of problems that actually do seem to be related. Our patients have eating disorders. They're binging and purging or restricting, along with cutting. Maybe an eating disorder that involves binging and purging has something in common with cutting. Well, in DBT, for many patients, not all, we'd have to assess it, but for many patients, we might see them as actually part of the same set of problems. We of course, could think about it as two separate diagnoses, but probably more useful to the therapist and more useful to the patient from a DBT perspective is to say, gee, these are part of a response class, part of a set of behaviors that this person is engaging in that help them to regulate their emotion. In some situations, cutting works. Other situations, cutting is not possible, but going to the bathroom and purging might. So there are a bunch of things like that that actually aid the therapist. Frankly, being a kind of simple person, I like to not be overwhelmed when I'm in the session, and having a set of principles that guides me and lets me think, okay, I don't have to deal with 7 or 8 or 9 different diagnoses this minute. I can deal with one problem that I know how to treat that actually might have different manifestations. That can be extremely helpful to the therapist, keeping the therapist from getting confused and dysregulated. Sometimes I think of dysregulation, the treatment is being built more to keep us from getting dysregulated than to help the patient, but I think that they're connected. Okay, so here's just an example of the model that we use. Now, the things that we've been talking about these couple of days, the actually really interesting presentations that I've been listening to about various genetic, biological factors, those things come in this model as we would call them emotion vulnerabilities. Those are things that contribute to an individual's emotion vulnerability. That includes, of course, temperamental factors, which might be genetic or biological, but also can be learned over time, specifically having to do with sensitivity and reactivity and so forth. I'll talk about in a second. So a person brings whatever emotional vulnerability they have to their daily life. And that vulnerability, of course, is, in some ways, it's a pattern, a style, but it's also state determined. It's got both state and trait elements. For example, for those of us who are on West Coast time, a couple of us, and it's almost time to wake up right now, being tired, maybe you jumpstart yourself with a quad espresso and skip breakfast, okay? Now, if some ordinary, relatively unpleasant event happens, we're not at our best to react to it. So we're emotionally vulnerable to that event, especially if we didn't get much sleep last night, maybe had too much to drink, these kinds of things. On the other hand, somebody who's on East Coast time has had enough sleep, didn't have too much to drink, had a good breakfast, only had one ordinary cup of coffee, that same person on a different day reacting to that same negative event, or what might not even be experienced as so negative, that level of emotion vulnerability then plus the event leads to a certain amount of heightened emotional arousal. Now, some of that is just what we bring to the situation all the time. Some of it's just our basic biology, however we got that. But some of it is our state, what we've done lately, the last 24 hours, whether we had an argument with a partner or felt really loved and cared about by our partner an hour ago, has an influence on our reactions to those events. So that arousal, of course, that heightened emotional arousal, looks like something. It might look like kicking and screaming. It might be very loud and obvious. It also might be very inside the person, with the person smiling through the pain, and actually looks like they're in fact not suffering. But the idea is that in BPD, that arousal is not expressed accurately very often. This is a key thing. The idea is the arousal isn't expressed accurately. An inaccurate expression could be too much, not the actual quality of the private experience, or it could be too little. But what happens is, of course, that when you don't express yourself accurately, it's very hard for people to support and validate your experience and help you manage it. Of course, what happens when somebody invalidates you? This is, by the way, we've done research. This is the kind of thing, if my grandmother were alive, she would say, You need to do research to understand this. She was a Russian Jewish immigrant. I know for Zeddy it doesn't fit, but trust me. And that's what she would have said. And she, like, you need to do research to know that when someone tells you that you don't feel what you feel, you're going to get more upset at your friend. Okay, so yes, you do. You need to do research to do that, because we find, in fact, that when we get invalidated, a bunch of things happen, not the least of which is our arousal goes up. Try it. You don't believe me? Go home. Say to your partner, next time your partner discloses something accurately, right, they say, oh, I had a bad day. Say, no, you didn't. You shouldn't have. You shouldn't have had a bad day. And see what happens. But don't blame me. Anyway, so when we get invalidated, then our arousal goes back up again, which, of course, makes it harder to express ourselves accurately. This is a normal process, of course, right? Just think about, I assume that most of us have said something mean or unpleasant to a partner or a child or somebody in the last 5 years. And if you haven't, that's good for you. But if you have, just think about, is that really were you accurately expressing when you said, you jerk? Was that an accurate expression? Or what you really mean was something like, gosh, what you just did really hurt my feelings. Now, saying, you jerk, it's not as easy for the person to validate that and say, gee, I really did hurt your feelings, I'm sorry. It's more like, no, I'm not a jerk, you're a jerk. It's much easier to respond defensively and to the content of what's being expressed, which may not actually be quite accurate. Anyway, the model says that this process goes round and around, and of course arousal keeps building until the behaviors that are expressed become extremely problematic. Now, the other thing is that these invalidating responses contribute to a pervasive history of invalidating responses, which contributes to more emotional vulnerability down the line. Now, we see this in ordinary families without BPD, people who have developed an enormous amount of vulnerability to a particular person or a particular situation, and then this whole cascade happens. And of course, we also see it in some individuals who bring with them an enormous amount of vulnerability and a heightened arousal, and all these things continue to cascade through. So that's the model. The nice thing about, there are many nice things about the model, but one of the nice things is that it tells us about our points of intervention. We can reduce vulnerability. We can change negative events and make them less common. We can work on reducing arousal. We can work on increasing the accuracy of expression, and we can get people to be more validating. And in fact, in a nutshell, those are the things that we're trying to do in DBT. Now, that vulnerability from a DBT standpoint actually has to do with three factors: sensitivity, reactivity, and slow return to baseline. Sensitivity just means your emotional sensitivity. Think about it as hearing. If you have sensitive hearing, that just means that you hear things other people don't hear. Well, if you're emotionally sensitive, that means that you're responding to emotional valenced things that other people might not notice or hear, respond to. They're really there. They're not imagined. It's just that other people don't react to them. Reactivity has to do with, okay, when you do notice something, how big do you react? Some people react in a small way. Some people react in a big way. There's nothing inherently good or bad about being more or less reactive. And some of us, when we do actually get aroused emotionally, it takes a while to come back to equilibrium. Others kind of pop right back, seconds or a minute later. This is this description these are things that we're all someplace on a continuum on, but the idea is in BPD, folks, that they have all three: high sensitivity, high reactivity, and a slow return to baseline. That means that as they bump into the ordinary daily events of their life, that they're bumping and they're discriminating a lot of emotional content. They're sensitive. They bump and they react a little bigger than average, and they don't come back quickly. So when they bump again, they go up some more and up some more and up some more, and they end up at a very high level of arousal. And at high levels of arousal, we're all vulnerable to whatever happens next. Now, having said that, I want to point out that emotion dysregulation isn't the same as simply having high arousal or just being upset. We could have very high arousal, be extremely upset, and not dysregulated. Dysregulated is a state of arousal in which we don't have the skills or the experience to manage ourselves in an effective way. So one person might, at a level of arousal that's very high, have lots of skills and lots of help, and actually may not be dysregulated, may function quite well. Another person at a similar level of high arousal may not have the skills to manage or the help to manage, and therefore may engage in lots of what we might think of as escape-oriented behaviors. In other words, their sole purpose narrows to, I can't stand this, I've got to escape this feeling of aversive tension, this high negative emotional arousal. Now, I use the term invalidating environment, and I want to be very careful about this because invalidating is easy to think about at one end of the continuum. When people are critical and mean and nasty, it's easy to see that as invalidating, and that's part of the model. But there are other ways to be invalidating as well. For example, somebody smiles and is pleasant and seems relaxed, and you ask, gee, how are you? And they say, I'm fine, I'm having a good day. And so you say, oh, great, well, I wonder if you could do me a favor, and you put a demand on them. But in fact, if in private their expression is very inaccurate, they're just absolutely miserable, but they're not showing you, they're inaccurately expressing their level of arousal, and you put a demand on them, that's very invalidating. Of course, there's no way in the world you could know that. Okay? So families, when we talk about an invalidating family environment, that doesn't mean that families universally are doing things that are mean and critical and unpleasant and abusive, although we know that some do. And in fact, lots are doing things that are at least appear to be and are intended to be warm and caring and nurturing, but are so mismatched to the experience of the patient that they're dealing with that they are, in fact, quite invalidating. Not because they could have done it differently necessarily. And we, in fact, see, and our research suggests that there's a huge continuum of family behaviors that constitute the families of folks with BPD. Now, in DBT, the core dialectic is between acceptance and change. And that's, of course, but in some ways, the definition of dialectics in a simple sense is being able to do two things at the same time that seem, in fact, to be opposite, that seem to be incompatible. Accepting and changing don't seem to be compatible, but in fact, in DBT, we find ways to make the therapist's behaviors, on the one hand, very accepting and validating, at the same time, oriented towards change and improvement and problem solving. So the change part is represented by behavior therapy, modern behavior therapy, with a focus on emotion, very different than what lots of us learned in our undergraduate educations about what behavior therapy might be. Modern behavior therapy, fortunately, has modernized, and we focus a lot on emotion as well as other things. But behavior therapy still is a change-focused treatment, focuses on problem solving using rationality and logic, and is quite experimental. On the other side of things, the acceptance side is mindfulness practice and acceptance and validation from the therapist, acceptance and validation from the patient for him or herself. The idea that one can observe and know things, know, for example, what you're feeling accurately. Recognition that there are paradoxes in the world. Sometimes the harder you try, the less you get something. And then it's a more experiential approach to moving forward as opposed to experimental. In DBT, we're endeavoring to do both of these simultaneously and consistently, do change strategies that reflect behavior therapy and acceptance strategies that reflect our mindfulness practice. Now, Dr. Bohus yesterday mentioned the stages of disorder, so I'm not going to spend much time on this, except to say that the overarching DBT goal, and the one with which we have to collaborate with our patients, is to create a life worth living. That's the essential goal of DBT that we start with. Now, of course, from there are all kinds of other goals, and those are within the stages of treatment and the various disorders that show up there. So starting in the pre-treatment stage, we're trying to get patients, of course, to commit to treatment and agree to whatever components of treatment are available. Stage 1 has to do with severe behavior discontrol. Stage 2, misery, or as Dr. Bohu said, quiet desperation. Stage 3, problems in living, and Stage 4, a sense of incompleteness. By the way, there is no Stage 5. The idea is that all people kind of living are in some stage of order or disorder. Incompleteness just means, anybody ever have the experience, your life is going well, and you say, so this is it, this is my whole life, that little existential moment that we have. As I look towards 50, I'm anticipating another one of those moments. So, I'm not going to go through these in detail because I think Dr. Bohus covered them yesterday. But I do want to mention something about emotions, because our understanding of the science of emotion is critical to our delivery of dialectical behavior therapy. lots of theorists over the years have made a distinction between primary and secondary emotions, not the least of which are Greenberg and Safran, who are not DBT people, of course, at all, but emotion theorists. And they make a distinction between primary emotions, which are our initial response to events, our initial way of reacting that are pretty normative, typically very adaptive and effective, as opposed to secondary emotions, which are reactions to those primary emotions, and those could be mediated by our thoughts or judgments about things, or they could be learned. In DBT, we're focused on finding primary emotions to treat and actually trying to extinguish or ignore the secondary ones. We think this is an incredibly important piece, which is why I think that we find our patients to be extremely shame-based, because they're ending up with a lot of shame as secondary emotions, sometimes anger as a secondary emotion, and instead we're trying to get patients to move back toward more primary emotions for them, which are typically fear, anxiety, sadness, and grief. So, for example, any emotion could be conditioned to elicit, for example, anger or shame as secondary emotions. In the same way, any emotion could, if we get judgmental, elicit either shame or anger. And the judgments, of course, if the person, say somebody cancels lunch, gee, I've got the flu, I can't come to lunch, and the patient was looking forward to lunch, how does the patient feel? I mean, what's the primary emotion? Disappointment, right? Looking forward to seeing their friend. Friend's not coming to lunch because the friend has the flu. So sadness would be the primary emotion, but if the patient says, gee, this person doesn't really like me, I'm not a decent friend, I'm a bad person, then of course they're going to feel ashamed instead of sad. Or if they say, this person's a bad friend, they shouldn't be standing me up at the last minute like this, for heaven's sake, I would come to lunch if I'd planned it, even if I had the flu, they're judgmental of the friend, they're going to end up in a very angry kind of response. And so our mindfulness training, of course, is going to try to help get rid of the judgments, which helps us get back to the primary emotion. Behavior therapy strategies in DBT are many. Behavioral assessment and behavioral analysis is a key thing, very detailed chains, understanding what is the sequence of events, especially privately, what emotional reactions, what kinds of thoughts, what kinds of judgments, what kinds of things do other people do that move a person towards dysfunctional behavior. We use classical conditioning theory, operant conditioning theory, and various behavior therapy interventions, skill training, stimulus control strategies, contingency management, various kinds of exposure response prevention interventions, and later in treatment, not in stage 1, but later in treatment, sometimes cognitive restructuring. So cognitive behavioral interventions are a key component of the change here. At the same time, mindfulness, practice, acceptance, and validation are the key acceptance side of the coin. Acceptance for our purposes has to do with, at that moment at least, not trying to change the person or trying to change his or her behavior, not putting energy into change, genuinely at that moment trying to understand what the person's experiencing and simply be with that experience. And then, of course, it's not validating if you don't communicate your acceptance of that. It doesn't help to simply feel it. You have to communicate it to the patient. The communication of understanding and acceptance, or what their experience is legitimate, how it makes sense, and the ways in which it makes sense. And it turns out this is an interesting endeavor, because validation, turns out that when you start to look at a particular behavior, sometimes an emotional reaction is valid in one way but not in another. It might be valid because of a lot of previous learning. If I were in a plane crash last year, and then we're driving by the airport and I get anxious, and you knew I had been in a plane crash, you'd say, oh, of course you're anxious because you're in a plane crash. But you wouldn't say, of course you're anxious because this is dangerous. There's nothing dangerous about driving by the airport. So it's valid in one way and invalid in another. And in fact, although we call it acceptance and validation, you notice that with problematic behaviors, like if I started to have panic attacks driving by the airport, you wouldn't want to just accept fully that. You'd want to accept the parts of it that are valid. Yeah, it makes sense that you learned this response, but you'd also want to invalidate the invalid parts of it. And, of course, you notice that it's not dangerous at all what we're doing. Because accepting me having a panic attack for the rest of my life every time I go near an airport is not a loving, caring thing to do. So, in fact, in validation, by validating the valid, it sets up our effectively being able to invalidate the invalid, which is also validating, by the way. Okay? It's validating the invalid and invalidating the valid that's actually invalidating. Okay, let me say that slower. Invalidating valid things, we all know that, right? You're not really tired, okay? That's invalidating. Validating invalid things, okay? Person actually, it's perfectly safe, and you say, you're right, you can't do this, it's really unsafe. That's treating the person as fragile and incompetent. That's very invalidating. But actually, when we validate the valid, that's validating. But actually, when we invalidate invalid things in the ways that they're invalid, that's strangely enough also validating. Just think about it as math. Negative times a negative is a positive. So, anyway, so this validation enterprise is actually a little more complicated than it might seem. It's not purely a Rogerian unconditional positive regard, although it's got an element of that in DBT. It's also about sorting out in what ways are things valid and validating it in the ways that things are valid and invalidating in the ways that things are invalid. We can do that verbally, but we can also do it functionally. There are ways to respond by taking people seriously and doing things, not just talking about them. And we have a team. The team aspects of the treatment are key, where we help each other become more skillful and deliver the treatment more faithfully, but also work on acceptance, support, and validation of the valid things on the part of the therapist. Okay, so that's a nutshell overview of what DBT is as a comprehensive treatment. There are more than 40 published studies, and I'm not including case reports here. Actually, I think it's now considerably more than 40. At least 20 controlled trials, most of which are random controlled trials, with adults, including elderly folks, adolescents, men and women, outpatient, inpatient, day treatment, forensic settings, carefully diagnosed BPD, people with significant BPD features, as well as mixed personality disorders, treating people with suicide attempts and self-injury, as well as substance abuse, eating disorders, depression, dissociative disorders, panic disorder, anxiety disorders, and various forms of family dysfunction. So it's been used quite broadly across a variety of different problems that actually all, of course, co-occur with BPD. Now, I just want to put in a plug. We emphasize, and I think appropriately so, our randomized controlled trials. And I think that in early stages of research, it's important to establish that our treatments work well compared to some legitimate alternatives, whether that's a treatment as usual or whatever the standard of care is in a field. We need to know, gee, does a treatment work as well as the standard of care? And I think that once we know that, and I think we have to have multiple studies done by multiple investigators to have confidence in that, but once we do, there are other things we need to know, not just randomized controlled trials, but other controlled trials. Some places you can't. For example, lots of inpatient units. Residential programs have one house. It's very hard to randomize people. But you could evaluate what you're doing with one version of treatment, then change over, and then evaluate how you do with the next. Of course, you have to look at cohort effects and so forth, but those kinds of studies are important. Implementation. Can you deliver the treatment effectively in a community setting, not just an academic setting? Terribly important questions. How much does it cost to do it? Are people going to be willing to pay? Does it work? Is it worthwhile? It's not just that. So we have to pay attention to cost analysis, healthcare economics. And when things are working, why do they work? What are the mechanisms? Doing mediational analyses, understanding the treatment process. And, okay, it might work, but do people like to do it? Are they willing to deliver this treatment, or is it too burdensome? So these are questions that we've also been concerned with in DBT, and we don't have all the answers to these questions, but we have at least some windows into answers about these questions. I'm sure many of you are familiar with Marshall Linehan's initial outpatient study, which was published in '91, and then the follow-ups in '93 and '94. I'll just quickly run through this because it turns out that this early study, unlike lots of research lines, has been replicated again and again and again, and in fact does represent, I think, what we can expect an ordinary DBT program to do on an outpatient basis. DBT was better than treatment as usual on all of these dimensions. That doesn't mean that there weren't other dimensions that DBT was effective. It means that it wasn't more effective than treatment as usual in other dimensions. But specifically, DBT did a better job. There were fewer self-injuries at the end of treatment and in the follow-up. And the percentage of patients overall with self-injury was significantly lower, along with the medical risk of those self-injuries. Fewer psychiatric inpatient days, lower levels of anger, lower levels of cost overall. At the same time, treatment retention was enhanced. The dropout rates consistently in outpatient DBT that seems to be run reasonably well is between 15 and 20%, and that seems to be true for everybody except serious substance abusers who have a higher dropout rate. And that compares to other studies, the dropout rates are between 40 and 60%. So this is a huge difference in attrition. Social adjustment is higher and global adjustment is higher in DBT compared to other treatments. At the same time, this sample, as well as several other studies, including a couple that were not done by Dr. Linehan, show clear one-year cost savings. This is a big problem with the literature, by the way, which is that our funding sources, and I'll just complain about this briefly, only allow us to evaluate 1 year of treatment. And for folks who, as Dr. Cohen has so nicely pointed out, have problems for a long period of time, 1 year of treatment just is not necessarily going to be enough for many patients. Fortunately, we've got some international studies coming down the pike that have provided 2 years or more of treatment that we'd be able to evaluate some of these things. But at 1 year of treatment, which is arbitrary, and then when you have to kick somebody out of treatment at the end of a year because it's a research grant, it's sticky. We have an open, randomly controlled trial going on in Reno right now, and it's tough. At the end of the year, people have sometimes they're ready to leave treatment, but sometimes they're 2/3 of the way ready to leave treatment, and clinically it's not necessarily indicated that you want to boot them out at this point, but you have to because that's what the research protocol says. But anyway, so all of these studies are unnatural in the sense that they're ending treatment at a year. But at the end of that year, there's a clear 1 year cost savings. In fact, DBT seems to cost about half as much as treatment as usual, despite the fact that DBT has all these components. We've got a treatment team meeting, we've got people teaching skills, we've got an individual therapist. There are a lot of things going on. Despite all those components, it's costing half as much because the outcomes are better. Because the savings comes from fewer inpatient days, fewer emergency visits, less medical utilization. It's also, of course, the case that treatment with high utilizers is going to save more. And if you try to do treatment with people who are utilizing fewer resources, it's not going to save as much. This has been replicated lots of times. And I want to point out that if you keep people doing well and returning them to work in the community effectively, that those cost savings will compound over time rather grandly. That's an interesting thing to think about. We don't know so much about provider satisfaction. There have been several studies, but none with random assignment. It turns out that therapists are not willing to be randomly assigned to learning a treatment and doing a treatment for the next 5 years of their life, like herding cats to get therapists to do things. So we'll probably never know this from a randomized standpoint, but we do know that when people enter into training to retrain and learn DBT, at the end of a year or at the end of 2 years, they are reporting lower burnout. Now, that may have nothing to do with DBT, right? It's not random. It may have to do with just learning something new, working on a team. We don't know. Nevertheless, it does mean that doing DBT isn't at least hazardous to your health. And that's, I find, comforting, having been doing this for almost 20 years. Okay, I want to just spend a couple of minutes. You've got a bunch of slides, which I don't intend to go over in detail because they would numb you at this point on a Sunday morning. Much too much data, but I want to highlight a couple of things that have to do with some myths that continue to persist about DBT, despite so many studies. One of those myths has to do with one I think I've hopefully disabused you of, which is that DBT is a one-on-one treatment, okay, or just skills training. DBT is a comprehensive, multi-component treatment, 5 different functions. The second myth has to do with DBT only working to help stabilize patients, that it doesn't, in fact, help people in other ways. Of course, that's true for some patients, and DBT by no means is a perfect treatment, as you'll see. But at the same time, DBT for some patients takes patients from stage 1, a stage of really out-of-control behavior, dysfunctional out-of-control behavior, with multiple suicide attempts and self-injuries, all the way to stage 3 or stage 4 in DBT terms, where people are not utilizing mental health services, actually living effectively in the community, having meaningful relationships, and working. In other words, JF scores, in the normal range, above 80, and we can say, reasonably speaking, that somewhere between 25 and 40% of patients actually do that. Not in a year necessarily, but actually do move to the normal part of the population distribution, and seem to stay there. Another chunk of patients, another third, get stabilized, but are still reporting high levels of misery, still reporting high levels of depression, maybe aren't working full time, and so forth. And then, of course, there are patients, about a quarter of whom DBT is a complete and utter failure. It's just a treatment failure. We don't help them. So it's not a perfect treatment by any means. On the other hand, it does seem to perform better than the treatments against which it's been compared. Now, the most recent study that's been published came out in the archives this summer, a study of 101 patients for 12 months, comparing ordinary DBT therapists with experts from the community. This was a Seattle study, so it's Seattle experts. They're non-behavioral experts selected by their peers to be experts at treating BPD. This particular study includes not just the treatment year, but another year of follow-up. And I'd like to show you these results because I think they're encouraging in lots of different ways. The main outcomes, by the way, the treatment by experts, that's the TBE. The treatment by experts, they were selected to be non-behavioral experts. And it turns out that most of them were practicing one or another variety of psychodynamic treatment. But of course, it wasn't a specific manual of psychodynamic treatment, although they did have the option of getting supervision at the Seattle Psychoanalytic Institute. The good news, I think, is that both the DBT therapists and the treatment by expert therapists provided treatment that seemed to be better than treatment as usual. If you look at benchmarks of treatment as usual, the experts really were experts. And I find that comforting to know that, that professionals, when asked, actually when they say, gee, so-and-so is really good with these particular kinds of problems, that's probably true. On the other hand, DBT, ordinary DBT, did better than the experts, the non-behavioral experts, on several important outcomes. DBT patients had fewer suicide attempts, both in the treatment year and the follow-up year. They had fewer hospitalizations with lower medical risks, fewer ER visits, and a significantly lower dropout. So despite the treatment by experts doing a better job, and I think it's very nice that the treatment in general in the community is getting better, the DBT was still superior in a bunch of ways. Now, if you think back to what I just said a minute ago about outcomes that have to do with just general well-being, the sort of longer term, sometimes what we refer to the deeper outcomes of patients, I want to address those for a second. So, for example, one of the measures that was used was the structural assessment of social behavior, which develops a bunch of psychodynamically oriented relevant scales. So these are not things that only behaviorists are interested in, or DBT therapists might be interested in, but the larger community of therapists from non-behavioral and non-DBT backgrounds might be interested in. And DBT actually did better than treatment by experts on all of these SASB scales. Patient interject change was improved significantly better than treatment by experts. Appreciate and value self was improved more. Attack and reject self went down more. Perceptions of the therapist's affiliations went up more. Perceptions of the therapist's autonomy down more. And things are right up, and therapist approaches, including love and concern, were more. Now, what's important about this, I think, I want to do a little bit of exploding of the myth that DBT only works at stabilizing patients. These are important, observable by third parties, these are coded by independent, blind observers, saying that these patients are doing things that actually are important developmentally. They're solid improvements on things that just don't have to do with only not cutting, not burning, not going into hospital. These are good long-term outcomes. Okay. I have one more minute, and I think that what I want to add here is just that you've got a bunch of slides that I've intentionally left for you, didn't have any intention of going over, that highlight replications to the original study comparing DBT to treatment as usual, extensions comparing DBT to specific other kinds of therapies, and then other populations like serious substance abusing patients with BPD, adolescents, inpatient studies, residential studies for adolescents, and then various extensions with elderly in emergency rooms with and without SSRIs, eating disorders, ADHD, mental retardation, and then a variety of aggression and violence and family interventions that we've studied. So DBT has now quite an emerging body of evidence to say that this not only is a useful treatment for stage 1 patients, but it's also useful for families and for stage 2 and beyond. And I think I'll stop there. Thank you.